Hello and welcome to today's webinar for mental health professionals, an old approach with a new twist, applications of inhibitory learning and exposure therapy, featuring Dean McKay. My name is Astrid Nasfar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the webinar attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio panel, and the dial-in information will be displayed. You will have the opportunity to submit any questions by typing them into the chat box located on the control panel. You may send in your questions at any time, and we will address them during the Q&A session at the end of the presentation. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation, and the link to the evaluation will be sent to each participant within 48 hours of this webinar. The post-test assessment will occur at the end of the presentation. The questions will appear on your screen, and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Dean McKay. Dr. Dean McKay is an ADA member and is also a professor of psychology at Fordham University. He is a past president of the Society for Science of Clinical Psychology and past president of the Association for Behavioral and Cognitive Therapies. He is board certified in clinical and cognitive behavioral psychology from the American Board of Professional Psychology. In addition to his professorship, Dr. Dean McKay co-directs the Institute for Cognitive Behavior Therapy and Research, a private group psychological practice. I will now pass the screen to our presenter.
And so I'm happy to present to you guys today for this discussion of the inhibitory learning model. Sorry, let me just pull up my slides a little bit out of sync here. So just give me a moment. My apologies for my delay in preparation of getting my slides on the screen.
Perfect.
Great, there we go. Thank you. Whoops. So, I went like mute for a second. Can everybody hear me?
Yes, we can hear you.
Okay, great. Thank you, Astrid. Okay, so first let's get some of the disclosures out of the way. I have no disclosures to report for this presentation. And so let me just provide you a brief overview of our plan for this morning, or this afternoon rather, for the webinar. So this is a more advanced webinar, so I assume that all the attendees have some familiarity with exposure. But nevertheless, I'm going to spend a few minutes reviewing briefly the classic exposure model for anxiety and avoidance reduction. I'll introduce the inhibitory learning model and the impetus for its development. I'll describe the 8 broad means for anxiety and avoidance reduction using the inhibitory learning perspective. We're going to illustrate each aspect of inhibitory learning through a detailed case example at the end, followed by a brief question and answer period. Sorry. Okay. So first of all, the majority of contemporary exposure approaches are reliant on the conceptualization that was laid out by Foa and Kozak in '86. At that time, exposure had been used a fair bit, but Foa and Kozak provided for us a pretty detailed conceptual discussion of the mechanisms that would underlie successful exposure treatment, which was a real advance because it allowed for us to understand certain benchmarks that would allow for us to know when a client has successfully navigated the task of getting the conditioned stimulus that led to fear to being one that would not lead to the same level of emotional arousal. So the central basis of that model was to present the target stimuli at some minimum sufficient level of intensity to, as they would put it, engage the fear structure that would lead to change. And the central mechanism at work was considered to be habituation and corrective learning through, in their words, a change in the information structures that set the stage for avoidance and the perpetuation of fear. Most of this would be ultimately be construed as basically a memory structure. And in order for that to happen, it was required there be some minimum physiological activation in order for change to occur. And also, it was the model that articulated pretty clearly that exposure that would be too intense would have adverse consequences, such as through sensitization. For example, it would consolidate fear information in those memory structures. So briefly, if we had to depict this model pictorially, it would look something like this. There's a target stimuli that's feared. There would be exposure, usually in vivo, to portions of the stimulus complex. There would usually be some imagery to accompany that exposure in order to enhance contact with the stimulus complex. I'm going to take a moment on that in a second. It would also be required to elicit some kind of physiological arousal, and that would lead to change in the information structures. So the imagery part, Foe and Kozak had noted, and this is where some of the cognitive functioning aspects of exposure come into play. They noted that in some participants, they would deliberately and strategically engage in some kind of thought process that would diminish the intensity of the exposure procedure. And so part of the task for the clinician was to run interference on that. I'm going to read for you briefly the most telling aspect of the Foe and Kozak article. A lot of people, I think, have lost sight of the fact that they had articulated this. So I think it's a really telling passage. And in it, they said the following. This is on page 30 in their article, if you happen to be interested in looking at some of this detail later on your own. They were talking about a client with contamination fear, and they were measuring physiological arousal during a specific exposure task. And so here's where the quote begins. During exposure sessions, urine was put on several places on his arm. A strong initial fear reaction was manifested in nervous movements, blushing, and a very high anxiety rating. However, unlike the gradual reduction of anxiety observed in most patients, a sharp response decrement within 3 to 5 minutes was observed with this patient. This pattern of high initial response followed by rapid decline was repeated daily. Long-term habituation was not evident. Inquiry revealed a curious avoidance technique. In his imagination, this patient first, in quotes, froze the contaminated spots to prevent their, in quotes, spread. Having controlled them, he stopped attending to them. In this case, the observed response decrease seemed not to reflect therapeutic emotional processing, but rather successful avoidance of the contaminant. So the role of imagery in this case has a specific function of making sure that things are not avoided further, even though the person is being presented directly with the stimulus that they report consistent fear provocation. So some outcome, just briefly, while we're reviewing the classic model, it's highly efficacious when it's applied in vivo. There are numerous meta-analyses that detail this for a wide array of anxiety disorders and anxiety-related conditions. They usually show large effect sizes for fear reduction, typically with effect sizes measured in effect size D of greater than 1.0 for primary symptom improvement. The research suggests that the maximal benefit is for in vivo with imagery. For example, it's most clearly documented in OCD and panic. It's highly efficacious in multiple formats, such as through guided smartphone applications and virtual reality. And despite what people have heard, rumor and hearsay and clinical lore suggests that dropout from exposure is higher than it is for other treatments. And so far, there have been a few reviews, meta-analytic reviews, that suggest that this is simply not the case. It's been demonstrated in PTSD. There's a very nice review article in JCCP, and in OCD, a review in Journal of Anxiety Disorders a couple of years ago. But when it comes to implementation, I think it's worth us asking a question, and that is whether clinicians conduct exposure strictly in the manner depicted in Foe and Kozak. So the essence of the Foe and Kozak model requires that there be a very focused application of exposure to the target stimuli, that It is essential that there be evocation of the typically aversive emotional experiences and that there be repeated practice in moving up the hierarchy. So if we take a pause and really think about what that means that every session that the client comes to the office, it is essential that they experience an unpleasant emotional experience at the hand of the clinician by way of applying a feared stimulus and moving up the hierarchy and consistently doing so. And the question that I think is worth asking is whether or not clinicians who were nonetheless conducting exposure, whether they typically did this. So prior to the inhibitory learning model being put forth in the literature widely, I found a few items that I think are instructive. This was in a structured treatment protocol that Chorpita's group did and was published in 2004, where they described exposure for children having fear and anxiety disorders as follows. Exposure practice exercises designed to teach the child through reasoning and experience that their anxiety is not necessary or is out of proportion to the perceived danger. It doesn't sound a lot like the way Foa and Kozak had depicted the application of their model. In another more broad-based investigation of processes that might underlie relapse prevention for anxiety, they described exposure in Ahmed and Westra. Specific instructions around expectation for change and tolerance of anxiety was considered palliative. Again, not quite the same as how Foa and Kozak described it. The one other thing is that I'll mention in other workshops that I've done prior to the inhibitory learning model being presented to the practicing clinician public, numerous anecdotal reports that people provided around their conduct of exposure suggested that the target was that they would elicit other emotional reactions aside from anxiety in the course of doing exposure. So we're going to see that some of that is consistent with how the inhibitory learning model is described and developed in literature. So this is my personal viewpoint, is that the inhibitory learning model is a clinician's model of exposure. It, as we will see in a moment, and I'm going to try to make the case, is that in essence, the different elements that are part of the inhibitory learning perspective are things that a lot of clinicians might have already been doing. And what's nice about this is it organizes it and structures it in such a way that clinicians can be a little bit more strategic in how they do things that they probably are already doing. So the primary learning mechanism that underlies the inhibitory learning model is that one would develop learned connections for behaviors that compete with other learned emotional associations. So the client comes in with a feared stimulus that they're reporting, something that provokes a lot of anxiety through phobia or other anxiety disorders. And the task in therapy is really just to help them develop new learned behaviors that interfere with those existing ones. Translated, that means that the elicitation of an aversive emotional reaction is not a requirement in order for treatment to be effective. In terms of application, that means there's multiple routes to implement this in order to accomplish this new learning mechanism. So I want to highlight something here. That translation that I have, it doesn't mean that clients won't feel an aversive emotional reaction. It just means that your task as a clinician is not duty bound to elicit that aversive emotional response. So it may happen, it may not, and we'll see how that unfolds. I'll show you in a moment. The benefit is that in knowing this, it has, I think, the potential for many more therapists to practice exposure therapy, because it would get past the very well-cited reluctance that many clinicians have to using exposure therapy. You may know of many treatment protocols that are ones that try to walk away from the application of exposure therapy specifically because of a desire to not have to create discomfort in the course of therapy. So the IL model, inhibitory learning model, I think can help facilitate that. So there are several routes to accomplishing this, and the inhibitory learning model articulates, at least in the Krask discussion of this, Krask et al. Had a classic article on this, now classic or well-cited article in 2014 on this topic, and there are 8 categories: expectancy violation, elimination of safety cues, conducting exposure in multiple contexts, practicing affect labeling, variable exposure along the hierarchy, a process referred to as deepened extinction, reconsolidation, and then occasionally reinforced extinction. So first, expectancy violations. So expectancies are a well-trod concept in the psychology literature. Basically, it's where as someone is expecting or predicting that a conditioned stimulus is about to be presented, they also anticipate the outcome. So anticipatory anxiety is what we are well familiar with, and what comes with that territory under anticipatory anxiety is an anticipated outcome. So the target stimuli, the person doesn't end up experiencing the anticipated outcome because they avoid it, or they do something else strategic to allow them to not come in contact with that conditioned stimulus outcome. In the course of exposure therapy, it can sometimes be designed in such a way that the actual outcome is at variance from the predicted or anticipated outcome. This is something that we all already are familiar with, and so expectancy violations, I think, comports most clearly with how most clinicians experience the practice of exposure. Client is expecting that they're going to feel certain kinds of emotional responses as part of the planned exposure experience. They conduct the exposure with the therapist. They fail to have that outcome happen, and then they benefit from the intervention. This comes from a classic set of literature, by the way. If you're interested in a deep dive on this, Robert Bowles in the early 70s conducted animal research to show that animals can predict outcomes for conditioned stimuli, and that you can get changes through exposure in this way. Interestingly, a little known article, an experimental article by Emetophobia group, showed the same thing, that it was not essential in order for you to get change as part of exposure therapy to experience anxiety. And actually, the title of their article was whether horror was necessary to produce good change as part of exposure therapy. So they were taking a particularly intense view of how this would go. And in their experimental illustration, the feared stimuli was presented in conjunction with things that were fairly pleasant in nature. So be like for insect fears, and you'd present the feared stimuli with flowers and other things that would be very pleasant. And so the participants did not feel the expected fear kind of outcome. And instead they felt, fairly neutral, and nonetheless they had a reduction in their fear response to the target stimuli. So here's a couple of examples that would be helpful for facilitating expectancy violations. So in contamination fear, you might have exposure to colorful flowers for the participant, and then you would remind the participant that these things grew out of the dirt. For social anxiety, the person might be practicing something that leads to embarrassment, and they have some blushing, and then you might comment on how the color of their cheeks is complementary to their hair. In panic, you might have someone practice deliberately focusing on the interoceptive experiences during exercise. And spider phobia, again, you might practice while the person is coming in contact closer and closer with spiders, and you start discussing how these things contribute to other kinds of benefits in the environment. Again, it runs in a way that is contrary to the prediction of the outcome. Each one of these scenarios, the client likely has a very catastrophic kind of prediction, and instead we're presenting something that is of a different nature. In social psychology, we might think of this as cognitive dissonance. Maybe many of you in practicing exposure think of it this way. And so we're just couching this in a particular format that's conversant with the inhibitory learning perspective. So occasionally reinforced extinction. I present this one next because it comports nicely with the idea of expectancy violations as its forerunner, even though we're going to comment on it in a moment for it being rather different in nature. So again, the target stimuli has some kind of anticipated outcome. We practice exposure, and we hope to get a different actual outcome. However, we do know that sometimes the actual outcome and the anticipated outcome can match. And so in recognition of that reality, it's useful to practice this as part of treatment in order to facilitate better coping with what real world consequences might be like. And I made this bubble smaller deliberately because the actual outcome may not be anywhere near as dramatic as the anticipated outcome. So here's my cautionary note about this. Occasionally reinforced extinction probably is something that you might plan for and develop later in treatment. So this is not something to do early. This is a later stage portion of the inhibitory learning model. Probably best after you've processed the majority of the hierarchy with the client. And it should also be for situations that are genuinely not harmful. So the person might have certain anxiety concerns around things that we would legitimately and for good reason be hesitant about. I'll give you an example. A student in our program has a client who is very worried about her neighborhood because of high crime that legitimately has been reported in her neighborhood. And so her fears have to do with actual bona fide harm coming to her. And so occasionally reinforced extinction is probably not appropriate for something like that. So we just have to kind of give some thought to circumstances where this is one that you might rightly practice. It's probably one of the few in those 8 that I listed before where this is something that we have to have as an important additional consideration. The elimination of safety cues. So this is one of those ones where in the typical course of exposure, we would predict feared stimuli leads to fear reduction. That's the standard model that we already discussed under the FOA and COSAC format. However, many clients have this additional arrangement. That is that they have with them some stimuli that provides additional relief. It's reinforced as a safety reminder that they're fine. If this stimulus is near me, I'm okay. It won't matter what happens. And therefore, they can approach the feared stimuli without any problem at all. It would appear even to the public and to the client themselves, and maybe to the clinician who doesn't have a trained eye for the safety cues, that the client, in fact, doesn't have a fear. Well, that's probably an unfair assumption. So there's a review of this, by the way, very recently by John Abramowitz and his student, Shannon Blakey, that's worth checking out on this if you want a deeper dive. As far as how to think about this, there's some controversy in this area. There are some people who are taking the position that a judicious application of some safety cues is fine and might facilitate treatment. And there are some cognitive models of treatment that emphasize this. And the data are still emerging on it. I would have to say that it's possible that we could construe some occasions where including some safety cues could be valuable. The clinician's task, however, I believe, is to distinguish between, let's say, normative and adaptive safety cues versus maladaptive ones. So to back up for a second, one of the common safety cues, if I back up to this slide, people who have treated clients with OCD recognize that a safety cue that sometimes happens is that the clinician, her or himself, might be a safety cue. That you ask the client to do something as part of exposure, and the client in their head says something like, I'm doing this with my clinician. There's no way that they would let me do something that would be harmful. They're, after all, kind of on the hook for my safety. So why would I do something harmful? Why would they ask me to do something harmful when I know full well that they feel responsibility for my well-being? This thing that happens is something that clinicians have to reckon with, usually by trying to practice some way of removing themselves from the situation by eliminating themselves as a safety cue. So that concept is at hand. On the other hand, if I refer back to my student who talked about the client who lives in fear of harm, that client has some safety cues that she probably should really heed. And the clinician's task is to identify with the client what ones are reasonable versus what ones are making this client's life not worth living. Another one that's a good example in the context of OCD and contamination fear, sometimes people who work in medical settings who have a high feeling of responsibility for their clients will worry about the contamination that they could bring to their patients. And so we have to think about what safety cues are germane for those clients. And so in each case, there are some reasonable steps that someone might take, and they may be, in fact, a step or two beyond what would be applicable for the average person because of idiographic circumstances. So safety cues is something that we have to assess carefully as to whether or not we should really eliminate them, and if so, what ones we want to eliminate. It nonetheless fits with the inhibitory learning perspective because we do know that usually clients have an excess of safety signals, and we do need to eliminate some of them. Exposure in multiple contexts. So here's the standard kind of scenario. Feared stimuli, single context, because you can only really, typically introduce one context at a time, at least to fear reduction. I'll illustrate where this went in a radical direction. A client that was at my practice that I co-direct was being seen by a different clinician who had also very severe contamination fear, sufficiently severe that hospitalization was required. He practiced exposure to the bathroom at the hospital, and he got very good at being able to use that bathroom at the hospital. When this client was discharged, he resumed having fear of pretty much all bathrooms and said, I'm great at doing exposure and being able to use that bathroom at the hospital. I still cannot use the bathroom in your office building, which, by the way, is not terribly dirty, probably similar in its sanitary qualities if you wanted a hospital. So what we see then is, if presented in a new context with no prior practice, it would appear as though the client had some kind of spontaneous recovery of the fear. So in order to get around this, we make sure that we practice in multiple contexts so that you get durable fear reduction. Again, I suspect strongly that many people who successfully implement exposure do this. It's a wise thing to do. And so this is something that, by the way, is available as a conceptualization from the animal research. So the inhibitory learning model in total is one that's derived from basic animal and basic human experimental research. Variable exposure along the hierarchy is one that may not be as commonly practiced, but it might be something that you've considered or have thought about when working with clients as you get closer to completion of treatment. So here's an example. I have just a rudimentary kind of hierarchy with some stimuli, spider fear kind of stimuli. So spider phobia, client whose fear of seeing just a photo of a spider, pretty low level of subjective units of distress. Small house spider is in a jar in the office, around 20. Small house spider under a cup on a table, so it could potentially be let loose, around a 30. Small house spider on a table and is free, and you see where this goes. After you've gone through all of these, exposure along this hierarchy in a variable way might be a somewhat random presentation. Start out with the one that elicits around a 50, then you quickly go to the one that's around a 20, then you go to the one that's around a 75, and you might do more steps than just this. And the idea is that it facilitates learning through new kinds of processing of information. So the new retrieval cues is reference to the idea that as you practice doing this kind of rapidly in variations along the hierarchy, the person isn't able to make good predictions about when and what kinds of spiders they're going to get presented with, and that the elicitation of fear is dropped accordingly because they're not going to be making predictions about danger because of size in some kind of sequence. It's just happening kind of routinely in a random fashion. It's the kind of thing that helps the client not have to deal with things like the element of surprise. So now your spider fearful person who has dealt with spiders in the office, and they say that they're planning a trip to go to the American Southwest, they're not going to be troubled by turning a corner while hiking and suddenly seeing a tarantula on the ground. So things like that would be helpful. And we know that for feared stimuli, the goal is for clients to feel comfortable with a wide range of suddenly and unexpectedly presented feared stimuli. That, after all, is the kind of thing that brought them to treatment in the first place, is that they were inadvertently being suffused with information that provoked the fear. And so the variable exposure along the hierarchy, even though it's a more advanced task, it illustrates well specifically the kind of thing that you would want to get in order for someone to have a really durable gain and for their ability to tolerate the world at large will be maximized. So deepened extinction. So deepened extinction is an illustration of where, let's say you have 3 smaller components of the conditioned stimulus, and you do exposure to each one of those smaller components. The person in question that you're working with gains mastery over each one of those 3. When you get done with it, then you have exposure to the fuller stimulus complex. So you have then portions 1, 2, and 3 combined. This again is probably the kind of thing that a lot of you have done previously if you regularly conduct exposure. Let me illustrate. So in contamination fear, so one might do something like the following. Have the client take a piece of tissue and they touch just a piece of garbage with that tissue and then handle the tissue. After that, they take perhaps a fresh, different tissue and tap just an empty, clean trash receptacle. After that, perhaps they take the tissue and they tap the edge around the top of a dumpster where large amounts of garbage is disposed. And then you would conclude by having contact with the dumpster directly, where garbage as well as trash receptacles all have appeared. So you would build up through smaller units of that same stimulus concept. For panic, you might do something similar. Interoceptive exposure, you'd start with dizziness alone, then shortness of breath alone, then maybe have them sweat. So maybe you'd turn the heat up in the office, or you have them stand in front of a small portable heater. And then you'd integrate the whole thing through hyperventilation challenge. For spider fear, you might do something like expose the person to a well-lit basement where there are clearly no spiders. Then perhaps you do exposure to just spider webs where there's no spider present. And then you integrate this by going to a dark basement where there are webs and spiders present. So that concept of deepened extinction is one, again, I think that we've inherently done, but allows us to now deconstruct a little bit the way in which to do it and to think along this line, because there is actually very good evidence, experimental evidence to suggest that this is an effective strategy to employ. So affect labeling. This is something that may be less commonly practiced. It's something that you probably have thought about, but it's worth highlighting the virtue inherent in affect labeling as a procedure to start incorporating in your exposure approaches. So again, the way we described it earlier, you have feared stimuli. When it's presented, there is an anticipated emotional response. Person practices exposure with you. They don't have the anticipated outcome, but they start to have some physiological arousal. You might ask the client to identify and name that emotional state. The supposition inherent in this is that through naming the emotional reaction, it helps the client to better regulate the emotion that they feel while experiencing this exposure task. One of the ways in which there's a very good review article, discussion of this that just came out in Cognitive and Behavioral Practice. And sidebar for a second, my mentioning this is part of a little bit of shameless self-promotion. My graduate student, Brandon Franks, and I just recently co-edited a nice, what I think is a nice special issue. Brandon really carried the water on this, so I'm happy to sound like I'm complimenting myself on this, but it's really Brandon that carried a lot of the work on this. Marks et al., that's from Laurie Zollner's group, where they articulated this in the context especially of treatment for PTSD, where the expected emotional response in session would be rather dramatic and intense for very good and justifiable reasons. And when practicing the exposure in session, affect labeling helps the client to better manage their emotional state, because it turns out that very frequently the actual emotional state that they experience is not as intense as the anticipated one. And so affect labeling serves a very valuable purpose in helping people to downregulate from where they predict things are going to go. It's also useful, at least in my experience with this, for diminishing the degree that clients have some kind of post-session adverse emotional reaction. So the scenario might go something like this. Client does exposure with you in the office. They practice a bunch of things effectively. They do great. By all intents and purposes, as you're meeting with the client, it seems like they've just been moving steadily along on the hierarchy. They leave your office. You hear from them 2 hours later, and they're telling you that they're feeling intense distress, maybe even saying things like, I really went too far during the session. I really overdid it. And their emotional reaction is one that they have a difficult time managing. If in the course of that session previous to this event happening, where they have this post-session adverse reaction, if you go through and you have the person name the emotional experience that they're feeling at the time, where you have them connect specifically with the physiological reaction that's being provoked as part of your exposure task, it diminishes the degree that these kinds of post-session adverse events might happen. So it's a valuable thing to incorporate. So reconsolidation, this is also one that has probably not been practiced very frequently. It may have happened by accident for some clients, and I'll illustrate how. So shortly before the session, you have the person come in brief contact with the feared stimuli, not to the point where they habituate. So they just have a brief encounter, and then they don't necessarily escape per se, but it's planned. They come in contact with it, and then they come to your office, let's say a half hour later. You practice exposure yet again with them under ordinary exposure kind of circumstances, and there is fear reduction. The process that underlies this theoretically, and there's some emerging solid experimental evidence to support this, is that pre-session exposure, that priming that's conducted just prior to the session, activates that information structure that Foe and Kozak discussed. You get it activated so that it's basically online and ready, so that when you do the exposure in session, it facilitates additional learning. So there's a little bit of arousal that's provoked prior to the session that sets the stage for more successful exposure when you practice with the client. The way in which you might do this will illustrate through my case example, but you want to make sure that you pick something strategically, probably lower on the hierarchy, before you have the session with the client. So again, this is one of those components of the inhibitory learning procedure that you would want to introduce after you've had several sessions of exposure. And you would plan with the client beforehand what they would do in order to have the reconsolidation event happen later. So like I said, Krask et al. Discusses this in their article back 5 years ago. There's been some additional research since then that seems to suggest that this is an effective strategy for helping to alleviate some of these kinds of fear reactions. And it really helps to galvanize the kind of gains that you may have as part of treatment. So let's put it all together. My remaining 15 minutes, I'm going to talk a little bit about this case. We'll go through some details about how this was approached. And I hope you'll also find an anecdote in the process of this case amusing. So briefly, this is a client who has a primary presenting problem of emetophobia. To remind all of you, if you're not familiar with emetophobia, it's a fear of vomiting or fear of coming in contact with vomit. I should mention, I'm giving some details about this client. I have taken the liberty of including some symptoms that she did not have. So I've kind of commingled this with another emetophobic client that I treated, mainly to shield her identity. So Beth, who was 34 at the time of treatment, unmarried, she's the member of a religious community, and she feels a lot of pressure from not only her parents, but from other members of her community to get married and to have children. She's committed to this. It's fully in line with her values to follow this path. She reports symptoms of emetophobia that are worse immediately prior to menstruation. She is not on medication at the time of treatment. She's had a lot of prior treatment before coming to my office, mostly psychodynamic in nature. She also did have a brief course of meridian tapping energy therapy. In the community where my private practice is located, there are several people who practice energy therapy, and so many people have come to me following that course of treatment. She has some additional anxiety symptoms of note. She has occasional panic symptoms. She reports being fearful of insects, and she has some subthreshold contamination fear. Her safety cues are extensive, and some of them include the following. She keeps on hand anti-nausea medication at all times. She checks her food extensively and asks others as well regarding the food quality when she's about to eat. And she also keeps air sickness bags on hand so that if she does feel the urge to vomit, she's prepared and ready to use it. I should add to this that during the course of her emetophobia, she never had to use her anti-nausea medication, nor had she had to use her air sickness bags. So these things have stayed with her long enough. The anti-nausea medication she reported usually expired and then would have to get renewed, but never had used it. She avoids a lot of places, or at least at the start of treatment, avoided a lot of places. She avoided restaurants extensively. She avoided bars. She avoided convenience store parking lots, particularly on weekends. If you guys are familiar with convenience store parking lots in some communities, late nights, they might be a place where some people might hang out, they might drink. Sometimes there might be high school students, at least the convenience stores in my town. This is what happens. And then sometimes people will vomit. And so vomit might be present, might be, often not, but occasionally. She avoids spicy foods for the risk that things will be potentially disruptive to her GI system. And she also avoids foods that are more than a day old, even if they've been refrigerated. So she's constantly going to the stores to get fresh food, and the risk of anything being potentially spoiled is too great a danger for her to take, and lest she might get sick and vomit. So the stimulus complex and hierarchy for Beth. So vomit-related stimuli. Some of the things that might elicit anxiety for her: vomit noises, babies, because babies do spit up very frequently. This was something that was very difficult for her. She avoided public restrooms, and that was something that was a source of considerable fear. Parking lots at nightclubs, and anytime that she might feel queasy. So she was particularly interoceptively sensitive to her GI tract. Anytime that she might feel any kind of unease in her GI system, this would somehow produce a lot of anxiety for her. Here's a portion of her hierarchy. It was much more extensive, but for our purposes, for the example, I thought it would be useful to just kind of break it down slightly. So quiet vomit sounds, for example, if she heard like in the distance, or if it was behind the bathroom door and there was noise around or some other kind of distractor, and she knew that someone was in the midst of feeling queasy and about to throw up, she'd feel about a 20. Videos of babies would be a 25. So the idea of seeing the stimuli is what kind of keyed her in. When she saw babies in person, then her anxiety went up even further. If she had to go to a public restroom in, let's say, an office, that was about a 40, mainly because her prediction was that you would not encounter vomit or people vomiting in an office restroom, as opposed to in a restaurant where she felt the risk was a lot higher, and in a bar, particularly high. If she was in the nightclub parking lot, then that was a 90. And if she felt queasy herself, that was the worst of all. That would be a 95. So how do we go about treating this using the inhibitory learning perspective? So one of the things that we did was we disrupted expectancies, and we practiced a lot of things around deepened extinction. We also worked on eliminating safety cues, which I'll illustrate in a moment. We then went to exposure in multiple contexts, and then we had occasionally reinforced extinction. So that was a sequence. We started out with disrupting expectancies and then went to deepened extinction, followed by safety cue elimination, multiple contexts, and then occasionally reinforced extinction. This is one of those kinds of fears where it actually was wise for her to actually experience it as part of treatment. Vomiting is an adaptive process. And so as a result of this, our goal in treatment was for her to be able to successfully throw up without being unduly distressed by it, aside from just the normal discomfort that comes with vomiting. And then we would repeat the process. So we went back to the beginning and disrupted expectancies some more. So we followed this in somewhat of a sequence, downward and then returned back to the top. What was embedded throughout was affect labeling. And then as we got into to the point of elimination of safety cues, there was variable exposure along the hierarchy. So here are some illustrative exercises that are in line with our discussion of the inhibitory learning model. So for expectancy violations, one of the things that was an initial task was we watched videos of animals vomiting with sound. The reason why this is a good one to think of in this context is that when animals vomit, there's all different varieties of the way in which this actually happens. Very different from when humans do. And so in order to do this, we stayed pretty distal from the target kinds of concerns she had. So we didn't go with babies vomiting very early on. We started with things that were pretty remote from the human experience of vomiting. Then what we did was we had some things where she listened on the other side of the door as I made vomiting noises. So At my office, for example, and many of you may have a scenario that's something that's comparable to this that would permit you to do this. There's a private single bathroom. I was able to lock the door. She stood on the other side, and I made vomit noises. Now, the way that it started was the noises that were made were quite different than the ones that she would be predicting. And then we moved up to where I made what sounded more like legitimate vomiting noises. I should mention this is the one I've told some people about this in the past, anecdotally. If you practice doing something like this, and if you treat emetophobia, just be careful about the pace at which you yourself as a therapist make vomit noises. I was able to successfully make myself so nauseous that I did throw up. I had to try and hold it back and wait until the client left. But I was very queasy afterwards. So just, a word to the wise. Practice some due diligence around how you're going to provoke this yourself. That was a novel experience for me. Fortunately, I'm over my emetophobia that resulted from treating this client, so you needn't worry about my well-being. Thank you. Deepened extinction. So what we did for that, given her queasy concerns, we did have her practice provoking very mild kinds of GI disruption, which can be provoked through instructing the client in pressing on their abdomen a little bit below the sternum. And so if the person presses in mildly and does it repeatedly, they can, excuse me, they can get a little bit of that kind of queasy feeling. So she practiced that several times in isolation. Following this, we had audio clips of vomit noises, only audio clips, because the visuals were what was more anxiety provoking for the client. We then had photos of facial expressions just prior to vomiting. This required a little prep on my part. So the advent of YouTube has been a boon for treating things like emetophobia. And it seems people love posting videos of themselves vomiting. There is an incredible treasure trove of these videos. And so I had to freeze the frame on a number of these prior to meeting with the client in order for us to do these kinds of exposures. And then we assembled all of it and ultimately built up to having her watching videos of babies vomiting. Because just like people like to apparently video themselves vomiting or their friends vomiting, there are adorable pictures of babies online, and then they spit up their formula. We worked on eliminating safety cues. So on several occasions, she left the office without her anti-nausea medication and went to a restaurant. So the way that we set the stage for this was that she would leave it on my desk. She would go out, and then we'd coordinate a time that she could return where it would be between sessions and she could come and pick it up from me. There's some restaurants not too far from my office where she was able to go and do this. We then, of course, practiced multiple contexts. So she went to restaurants during the day. If you go to restaurants during the daytime, especially on weekdays, there's more business lunches that are going on and things of that sort. Things that are less likely to be scenarios where you might encounter people who are feeling sufficiently nauseous that they run to the bathroom and vomit. Again, the risk of this happening, by the way, is pretty low anyway, but nonetheless, it was something that she was acutely concerned with. So we practiced that, and she went to a restaurant that had a busy bar scene, but during the day, and then she returned to each of these on the weekend, weekday evenings, as well as on weekend evenings. We did practice occasionally reinforced extinction. I started out with her spitting water out of her mouth that was not swallowed, and then juice and other mild substances. We did get to the point where she did provoke herself to vomit during the session for a water and juice mixture. And throughout, she was naming her emotional experience. Most of the time, she said she felt amused. She was particularly amused by my vomit noises. She was amused by a lot of the other stuff. And when she went to the restaurants, that was something that she found to be generally quite favorable, and was able to practice that successfully. So remember, I'm emphasizing that for each of these exercises for this client, anxiety was not really the dominant emotional experience. And she did have good change. As the presenter, of course, I have the luxury of being able to bring to the table cases that were successful. So Beth, I'm happy to report, did quite well. She regularly goes to restaurants, eats a wide variety of food. She stopped checking her food quality. And the last I checked with her, 6 months after treatment, she was in a serious relationship and was engaged. So come to a nice, happy conclusion. So with all of that, I'm going to thank you. We have about 10 minutes or so for some questions. So I'm happy to field any that you might have. And I'll take your questions now. Astrid, what do I need to do to make sure I see the questions pop up on the dialogue?
Yes, give me a second. I'm just going to switch back to. That's okay. Thank you very much, Dr. McKay, for that wonderful presentation. As a reminder, you will be able to submit any questions from today's presentation in the chat box on your attendee interface. So we'll just give our attendees a minute to type in any questions they may have.
Of course, sure.
All right, we have one question. I'm not sure if you're able to see that, Dr. McKay. I can read out loud.
Yeah, I don't see it.
Sure.
Sorry.
It's okay. Could you comment a bit on opportunities for new learning when the outcome expectation is emotional distress and with exposure, the distress actually occurs?
So wait, could you repeat it again? I'm sorry.
Sure. Could you comment a bit on opportunities for new learning when the outcome expectation is emotional distress and with exposure, the distress actually occurs?
Mm-hmm. Gotcha. Yeah. Well, so I guess the difficulty here is that, remember, the inhibitory learning model emphasizes that anxiety and distress is not essential. It may happen, though. And as a result, we have to prepare clients for the idea that it might happen nonetheless. And so it might also be worth thinking about and preparing the client for the idea of it being experienced in a smaller gradient, and to practice then naming the emotional experience, not just as generally distress, but in gradients of emotional language, because the affect labeling component capitalizes on the fact that our language is pretty robust with emotional language. And so we'd come up with some terminology potentially with the client around processes other than just distress, or other than just, let's say, the most intense label for distress. So we might say, okay, well, do you feel just discomfort? Do you feel, some other kind of level of unpleasant experience? And then the follow-up would be, to what extent is this tolerable? And can we just kind of stick with this because our goal is to have that ultimately feel less intense? So I hope that that's answered the question. I'm happy for a follow-up if it was not clear, or if I didn't quite address the main content that was being raised.
All right, our next question. Can you suggest 1 or 2 primary resources to learn more?
Sure, yeah. So I would definitely recommend the article by Krask from 2014 rather. So my last slide, and I'm happy to send it to you guys, or if it's available, I could, if you're willing to send the slides around to the registrants. The last slide, I have an extensive reference list, and so the resources that I would suggest. So again, I'll be a little bit self-promotional. It's not a conflict of interest because I make no money on people reading the journal Cognitive and Behavioral Practice. But the current issue of that journal has a special section on inhibitory learning. My student Brandon and I co-edited it. There are several articles in there that focus narrowly on each of these components that we discussed today. So there's an article in that special section on removing safety cues, on affect labeling, on more broadly how to do this in the context of treating children. So there's, I think, 9 articles in the special issue. And so I would recommend that. And in the reference list also, there's, as it relates to safety cues in particular, the Blakey and Abramowitz article is listed there. So those are some sources that I would think of, right off the bat. There aren't any textbook discussions of this as far as I know. And so given that it's fairly recent in the published literature, but those I think would be solid sources to start with.
All right, thank you. And as a reminder, today's presentation slides will be sent to all registrants in the follow-up email after this webinar. Our next question, okay. Did you make your client actually vomit? And if so, how?
So I had instructed her, I had asked her to do it. Obviously, it was one of these things where through collaboration, she agreed that this was going to be a necessary step. One of the things as part of that client's treatment, and this has been the case with other people with emetophobia, they recognized that there were circumstances that might come up where vomiting could legitimately happen. And so in her case, one of her goals is that she did want to have children. And she recognized full well that in the course of having children, then she might have morning sickness and vomiting might happen a lot. And so the way that we did it was pretty limited. I'd asked her to swallow some water and juice, and then I asked her right after doing it. So it was immediately after and not one where she'd have to provoke intense levels of retching, but to simply stick her finger down her throat immediately after. So it was a really brief time afterwards rather than one that would be where it was further down into her abdomen. She did this on her own as part of the session, so I gave her the privacy to go do that on her own. I've described this to other people, and the question comes up around, client dignity and things like that. So this was something that, was pretty clearly an independent activity. I stayed in the office as she went to the bathroom, so I was not even listening in as she practiced it. And she reported to me that she successfully did it. And I think she was a pretty good reporter of these kind of things because she did a lot of other activities successfully on her own and reported good success.
All right, the next question. What is an average length of time to work on a specific fear or anxiety or level of SUDS SUDS before moving up on the hierarchy?
That's kind of difficult to answer because it's so highly variable. Some people kind of need a lot of time for one particular item on the hierarchy. And further, in some instances, as you're focused on that one item on the hierarchy, it reveals that there were other components of the stimulus that you had not previously anticipated. And then it requires that you back up and you do some other things. So it's a little hard to predict that. I try to allocate adequate time to really make sure that the client is comfortable with the item on the hierarchy, and I'll ask if there's anything else that I'm not noting or that we had overlooked in constructing that item and the predicted level of anxiety that it would provoke. Generally speaking, by the way, while we're on that note, and some of you may be familiar with this phenomenon, people tend to overpredict how fearful they'll be. So when you construct the hierarchy, they may say, oh, if I feel queasy, like in my client Beth's illustration, she predicted that queasiness would lead to a 95. When she experienced mild levels of queasiness in the office, and she had a hard time distinguishing between mild and more severe, when she practiced that interoceptive kind of experience in the office, she didn't experience a 95. She experienced more like a 40. And so that over-prediction of anxiety is a pretty common process. It is, I found, actually more common if without preparation people have a post-therapy adverse reaction. But within sessions, and if you really devote the time to it, you can get good anxiety reduction, usually within the context of a 45 to 50-minute session.
All right, next question. Were there any times your exposures were refused by Beth or others, and what was your response specifically?
Oh, people refuse to do stuff that I request all the time. So I guess there are two ways to think about that. One is to ask the question about whether or not the concern is with safety, and safety like with regard to safety signals like we discussed before, and whether or not the person feels that there is some way that their fear is, let's say, valid. And then part two is if it seems that that's not going to go anywhere, to present gradients downward from the initial requested exposure task. So I'll use, instead of, let's say with Beth, the context, yes, she did refuse some things early on. So when we were doing some of the video exposure around vomiting noises and then vomiting videos per se, she had trouble with doing things, animal exposure that involve, let's say, dogs and cats. So animals that we're familiar with. But animals that were out in the wild, and there's videos, it's amazing the amount of material that's out there, videos of giraffes vomiting and gophers vomiting and squirrels. She was fine with all of that. It was as we got closer to things that were more domestic that she turned it down before we finally were able to get to it. So when that happens, it's just a matter of kind of backing off and thinking about something that will be more readily tolerable, but not escaping it altogether.
All right, thank you. The next question. Is there a minimum number of strategies a therapist should use for the inhibitory model?
I don't think so. I would say, you know, you have to go with what your conceptualization suggests will be most effective. I would imagine that you would want to try and pick probably 2 or 3 to feel confident that the gains have been solidified. And I guess if we had to choose 2 out of the entire list of 8, the 2 that I would say are most salient would be expectancy violations and exposure in multiple contexts. To the extent that you can successfully mount an effort around the other 6 as well is all for the better, and will likely lead to a more firm gain in the treatment. I would say, though, in addition, that question is subject to some investigation. It's not really clear to what extent one needs to rely on, let's say, 4 or 5 or all 8. To illustrate one more step further from that, so right now I'm doing research on misophonia, which is a strong aversive reaction to certain classes of sounds, and we're doing treatment with children. We've only been using 5 out of the 8 strategies that are part of the inhibitory learning model, mainly because we find that it's hard to come up with ways to have occasionally reinforced extinction for misophonia, because there really isn't any kind of outcome that the person has aside from feeling lousy. And so that one, the affect labeling we've certainly been using. And we also, and I'm sorry that I kind of brought this up and I'm kind of forgetting the other 2 that we've eliminated from the group that we've been practicing. I can, if anybody's interested, I could show you that. I could share that another time. But but we've been relying on 5 out of the 8, and it's been going quite well. We've been relying on expectancy violations, removal of safety cues, affect labeling, multiple contexts, and reconsolidation.
All right. We do have quite a few questions, but we unfortunately do not have enough time to answer all of them. I will read one more question, if that's okay with you, Dr. McKay.
Yeah.
Okay. Your examples of expectancy violations differ from my understanding of this aspect of inhibitory learning. I think of the violations as violating what will happen if I do X. For example, if I get very anxious prior to a work meeting, people will notice and negatively appraise me. That seems different than the idea that there is inconsistency between features of a situation. For example, flowers are pretty but come from dirt, which is potentially contaminated. Oh, that was a comment. Sorry.
Oh, okay. Yeah.
I don't know if you want to comment on that.
Yeah, I mean, so I'm not sure how much at variance I am with the example. I mean, the person is making a prediction about the outcome that they are thinking will happen if they're exposed to the feared stimuli. And so, you know, each of the examples that I had were around how to set the stage for the violation of what they're predicting. So if the person is predicting that they're going to come in contact with dirt and it will be a problem for them, then flowers, you present them with flowers and you tell them where their origin is, and now it flies in the face of how dirt would actually function based upon their prediction. And so that was how that example was inspired. But I appreciate the comment, and certainly I guess what's worth also knowing is that those 8 categories of the inhibitory learning perspective are not independent of one another. There's some overlap among them, and so you could construe of ways that there is a crossover among each of the categories.
All right. Unfortunately, that's all the time we have for questions.
Yeah.
We apologize if we were unable to get to your questions today. Thank you
Thanks,
so much,
everybody.
Dr. DeMckay, and thank you so much for attending today's webinar, everyone.
Thanks, everybody, for being here. It was a pleasure.
Thank you, everyone, and thank you to our participants for attending today's training. You will receive an email shortly that includes the link to the webinar evaluation, as well as a link to the recording of this webinar. For those seeking CE credit, the post-assessment will be distributed after these few announcements. The post-assessment will also be included in the follow-up email if anyone is interested in completing it at a later date. If you are not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ada.org to learn more. On behalf of ADA and our presenter, we thank you so much for joining us today.